It's a pleasure to be here to talk about the role of nutrition and detoxification, both in pain and inflammation. It's a lot to discuss, but as we'll talk about, they're all interconnected, and it's an area that we really could do much more in finding the interconnections to help our patients who often are dealing with not only pain, but also inflammation, issues with toxin overload, and a reduction in their quality of life based on all the factors that come together. And the goal is really not to fragment those, but find unifying ways to support our patients. It's really an area that we often look at as far as, can diet help our patients? We all like to think so. We all endorse it and talk to our patients about it. But in many cases, our patients don't fully accept the power of nutrition. That's been shown in several surveys, that it's a struggle, and it can often be seen as too complicated. So part of our work at Scripps, which we'll describe as part of the clinical trial at the end, is how do you simplify it in terms that patients can incorporate and begin to see improvement in their quality of life. And one of the reasons our patients don't often acknowledge that this can help is because we know in their pain management journey, they've typically been through the ringer, for lack of a better term. They've gone through many different fragmented approaches, procedures, medications, etc. And as the most recent best practices interagency task force, which I was able to be a consultant on, concluded, we still have many barriers, many challenges in helping our patients receive adequate care. And I think one of those is, how do you help them in a practical way incorporate lifestyle change? One of the ways we can do that is by bringing a team approach together. And again, this is just a preview of the study we'll be talking about at the end. And one of the key things, as important as the conclusions, are the type of collaboration and teamwork that we were able to put together, bringing together physicians, nurses, public health experts, naturopaths, behavioral experts, exercise experts, who all have a part to play in helping our patients move away from toxicity, pain, and inflammation. The challenge really becomes is that when patients hear these terms of detoxification, they often, conjure up images of what they've seen in the media of, it's quick, it's going to have overnight results and won't take much work. The fact is, we know it does take a lot of work, and it needs to be part of a long-term approach. And that's in the public arena. In the scientific arena, detoxification, we know, also can be a difficult term to understand. It can sometimes be borrowed from the lay press to be unscientific, and be not really something that we should discuss with our patients. The fact is, detoxification is something that's well accepted as part of working with patients in many populations, whether it's post-chemotherapy detoxification, issues with liver detoxification, and it can be a very scientific, very practical approach. And that was also part of our goal, is to help our patients really understand detoxification. So with that as a preview, I wanted to talk a little bit about the state of pain in America, because that's important to acknowledge of why we need new approaches. I also want to talk about how nutrition can promote inflammation and pain, get a really good understanding of what we need to reverse before we try to reverse it. And finally, what are some of the approaches that can help us reverse that vicious cycle that can incorporate so much of what our patients are going through day to day. And finally, a little discussion of detoxification interventions and how to do them either as a standalone or part of a integrative approach. So when I talk about pain, and specifically pain management in America, having been a director of pain management at the Scripps Integrative for 20 years now, and seeing the pendulum that's happened with pain medication, pain management in general, the Joint Commission's directive to treat pain as a number, which we know was very catastrophic. I try to look at pain management and pain in America really as the C's. So starting with the first one, which is, it's very common. we tend to think that we're doing a great job of grasping pain, treating pain, reducing pain. And the fact is, even though we've had by far the most powerful prescription agents over the last several decades, it really hasn't done much for pain management to stabilize disability and the level of pain. It's actually increased over this time frame, so that we've gone from 120 million Americans to almost 180 million Americans with pain, and approximately 40% of the population. So that's recent data from the NIH that was published in Pain. The other C is costly. We know when we look at pain management, it is the most costly endeavor we have in medicine. And that's because it overrides multiple conditions. So you can have angina and cardiovascular health, you could have diabetic neuropathy, you have cancer-related pain, and the list goes on. Or the pain can be in of itself, somebody with fibromyalgia that comes in, or other types of amplified pain that may not have to do with another condition, but are significant burden on the quality of life and can be very costly, as multiple studies show, in those with pain, much higher medical and life expenditure. The next C is really catastrophic. I don't need to tell anybody that's listening today how catastrophic it's been. We've all been touched by patients' families, maybe our own families, who've been caught up in issues with pain management, pain pharmacotherapy, which has recently also transitioned to illicit use. It's a very sad chapter in our medical history, and something that hopefully we'll get a better balance on as we go forward. Probably the most important thing when we talk about pain management is the complexity. No integrative practitioner of any background needs to hear this, that pain does not stay in its own silo. When somebody comes in with pain, and this is just looking at the example of chronic neuropathic pain, it tends to spread very quickly to all aspects of life, whether it's causing insomnia, fatigue, issues with cognitive fog, mood changes, anxiety, depression, changes in how we eat, and most importantly, what we eat. As many studies have shown that patients who begin on the pain journey and extend that journey and progress on that journey drastically change how, what, when, and how quickly they eat, which then adds to the inflammatory burden. So following through this model of the complexity of pain, we need to come up with a clinical care model, as this conclusive study from this study from the VA concluded, a care model that really puts together this complexity and tries to come up with approaches that make sense. And that, without naming it in this study, is really a definition of integrative medicine. And that I think is the best approach for patients who have progressed on that pain journey and really are feeling that complexity. We also need to look at approaches that not only help with inflammation, but know how that inflammation affects the autonomic nervous system, knowing that it can increase chronic cortisol, cause adrenal issues. As many of us are aware, we need to understand how we can hopefully approach and balance that out, both with diet and lifestyle, with things like exercise and mindfulness. One of the key things that we also see in our patients, even if they're not on medications, is that it can have a significant effect on their cognition and their cognitive abilities over time. Very startling research showing the longer patients have pain, this is looking at a chronic back pain model, the greater the increase in brain loss. So there is a significant change that basically advances the aging of the brain the longer we have pain. So I take it very seriously when patients come in early on in their pain journey. What can we do so that this doesn't turn into years or decades, which we know can also affect their cognition? One of the other things that has, I believe, gotten us into some of the troubles we've had is that taking an acute care model, the more you do, the better results you get, and translating that into chronic pain and thinking that we're going to get the same results. And we know that that does not equate to positive outcomes. We know that in most chronic diseases, when we have an appropriate chronic care model that appreciates the chronicity of that condition is different than when it's in an acute setting, we get much better results. However, if we look at musculoskeletal issues over time, this is some older studies, we have increased disability even if we have more tools or more approaches. So it's not about doing more, it's about really supporting it and individualizing the patient. If we look at more recent studies going to 2012, also similar, the purple is musculoskeletal issues. And again, one of the few chronic diseases that we just have not been able to appropriately grasp and manage. which is one of the main reasons that patients with chronic pain, as we all know, go outside the conventional toolbox to look at any approach which might be helpful. That includes things like chiropractic care, dietary care, mindfulness, etc. The problem being is that in some cases, on almost half the cases, patients may feel fragmented in this journey, that they are seeing multiple providers, most of whom are not connected to each other, which goes back to the importance of that collaboration and that team approach to get the most benefit out of these approaches, which can be helpful, but it can also be overwhelming trying to navigate. The evidence is pretty clear. I'm not going to spend too much time on the fact that when we integrate, meaning we add integrative approaches such as mindfulness and exercise and acupuncture and manipulation to conventional care models, we get better results. And in some research, we also know that both in an outpatient setting as well as inpatient pain care, that can have significant ability to reduce cost of care. So we have both improved medical care, we also have an improved financial care model when we integrate, because the more you invest in it, in many cases, we have a more empowered patient and someone who's more able to manage their pain long term. So that is one of the reasons that over the last, I would say, 3 to 5 years, we've had a plethora of guidelines come out to look at the importance of integrating chronic pain with non-pharmacological therapies. And those are wonderful. And I believe those have gone a long way to change the paradigm to something that's better for the typical pain patient. These are many times approaches that patients are doing in a integrative clinic, whether it's acupuncture or manipulation, and some that they're doing on their own. But one of the key things that we see missing on this is that there's very little, if any, mention of diet and supplementation and working on one's environment when we're trying to manage pain. So I think it's really important to know that this is a positive trend, but it's a somewhat incomplete trend, and something that I've been aware of, and my colleagues in integrative pain management are very aware of. If we're going to change the state of pain in America to help patients with complex pain, we really need to look at how we can incorporate nutrition. And one of the key things that's important with that is to understand that many times patients don't understand fully how nutrition can really improve their pain. They may know that something may not be healthy to eat, but really do they understand what a significant impact it can have for their inflammation. So that's one of the key things that we do with our patients is try to help them understand and try to reverse what oftentimes is a question mark. When I look at a lot of the pain literature, it is not the same as literature you would see in a diabetes journal or a cardiovascular journal, where they definitively say, if you follow the Mediterranean diet or an anti-inflammatory diet, you're going to find improvement in cardiovascular or diabetic endpoints. When we look at pain management literature and it talks about diet, it's almost always as a maybe. It's maybe as a question mark. And that's unfortunate. Even in positive trials, there's a question mark at the end, which is very frustrating, because if we want our patients to endorse it, we as clinicians need to fully invest in also endorsing it. So this is just a few examples of journals over the last few years that have done that. And I think that's changing, but not quickly enough. And one of the reasons we question nutrition as care providers, and again, I think I'm not speaking to the folks that this is most likely addressing, but in many aspects of conventional care, we just have not gotten appropriate nutritional education. And I would say I'm the first one to acknowledge that, both in medical school and residency, which is one of the reasons many of us interested in this area have done additional electives and fellowships and trainings and these types of webinars to begin to change what we know is a very poor background and lack of acknowledgement of the importance of nutrition. And once we do that, we're able to take that message to the patient and talk to them about how does your diet affect your pain. And one of the key things we start with is just looking at the typical daily intake, the state of the plate, as it's called. And we know that in many cases, the state of the plate is quite pathetic, for lack of a better term, in that it is mostly processed. Even without looking at the origin of the food, whether it's plant-based or non-plant-based, it tends to be highly processed. And we know in a number of well-done studies that the more processed, the more a food goes from a whole food derivative to something that becomes something in a plastic package, or something that's a quick grab and go meal, it tends to not have all the nutrients that we've already heard about that are so important in supporting endocannabinoid system, our inflammatory system to become de-inflamed, etc. So the vast majority, 2/3 of what most of our patients are getting in is processed. And we also know that our patients typically are getting only about 10% are getting appropriate fruits and vegetables. So one of the key targets is very simple: increase whole foods, increase fruits and vegetables, and not worry too much about the details as a starting point. If you can begin that transition, we'll talk about a little more about how we do that. So we talk about the standard American diet that many of our patients endorse, and we ask them simply, how many fruits and vegetables do you get? Where do you get them? Are they fresh fruits and vegetables? Are they what they perceive as fresh fruits and vegetables, but they may really be parts of either highly processed or mixed in with refined carbohydrates in juices and things like that that are not really giving them the nutrients that they perceive. We also talk to them about what types of foods may be allergenic. We talk about how they're cooking their foods, with the importance of avoiding glycation products, cooking more in low heat, not as long, and etc. We talk about also being mindful of how they eat. In many cases, patients are, as they go on the pain journey, looking at convenience foods. They're looking at quick hit foods, as we call them, quick gratification with very high fats, high salt, high refined carbs, which may have a momentary improvement in mood, but have a long-term inflammatory cascade. We also know that the speed with which it's taken can also be an inflammatory process. So we try to go through this, and we talk about how diet is one of the most important things that patients on their own can do to affect their long-term health outcomes, not just for pain, but as we know, with many cardiovascular issues, it is by far the largest target. We also have good mechanistic research that if you have the standard American diet over time, you will become more sensitized to pain. So when I talk to a fibromyalgia patient who is having more pain flares without any provocation, in many cases, part of it could be looking at their diet and looking at, where are your fruits and vegetables coming from, or lack thereof, and talking to them about how this can actually increase pain sensitivity and provoke pain. And the thing that really helps patients understand this is gut inflammation and gut symptoms. Many of our pain patients on a standard American diet have some level of gut symptoms, and that begins to create a bridge to understand when we are processing these foods as part of the standard American diet, it can have a significant impact on how we are able to either affect pain or inflammation or increase it. So this Big Bang theory is one that I think more and more is getting endorsed, not just in integrative circles, but in conventional medicine, looking at gut permeability, looking at leaky gut, and the fact that as gut permeability increases, a number of inflammatory issues, which we know affect our ability to really affect inflammation, is reduced. And we have toxins, including LPS, that we are going to be talking about, as well as zonulin, that are significantly affecting our ability to affect our inflammatory cascade. One of the other key things that we want to think about at this point is the fact that in many cases, when patients are increasing their gut inflammation, it does not stay in the gut. It goes into the shoulder joint, it goes into our bloodstream, it goes into many areas that then affect our ability to truly reduce pain. So in many cases, what we are doing is not really helping our patients when we are changing their diet in small ways, but we are really trying to help them make global changes that are going to help their mood, their sleep, etc. We're going to talk a little bit about these cascades. As clinicians, we often look at basic measures of inflammation like CRP. One of the key things that we need to think about is we don't always have to do highly esoteric blood tests. We'll talk about some of the ones we did as part of our research study, but in many cases, we can do really well with just things like CRP, or other inflammatory markers that we might do in a normal arena of care. So when we do these normal markers, we know that patients that have higher levels of CRP often also have issues with pain. In fact, most of the studies show that when we have an increase in CRP, we typically have an inability to manage pain as effectively as when we have lower CRP. So just by checking that CRP, in many cases, we are able to tell our patients, this is not only affecting your heart disease risk, your diabetes risk, but it's a significant factor for why you're having these pain flares that we are unable to manage with our conventional tools. One of the key things that I also talk to patients about is abdominal obesity. One of the effects that we often see with this is the fact that abdominal obesity is increasing. Even though certain sectors we may be hearing are having less weight issues, our abdominal obesity is increasing as a nation. And that is probably the scariest aspect of kind of what we've talked about, the increase in obesity. It's not the actual weight in pounds, it's where that weight is distributed. And because it is ending up in areas that are contributing to that and are part of that big bang, we are having increased levels of inflammation, which are exponential, more so than if that weight was elsewhere. We also have very clear evidence that that increased weight causes an increase in pain. This is a review article that I've cited, and this is a study of over 1 million Americans, which shows that as pain increases, especially in women, and especially as we age, it increases pain across the board. And there's many factors to that, but inflammation is one of the big ones that we see. And in fact, the American obesity rate, which many of us are familiar with, is nearly twice the average, which you see in yellow across all industrial countries. So it is definitely a very scary trend, and similar to the increase in pain, which I think are both are quite connected, are things we have a hard time connecting. We also know that one of the other promoters of inflammation and pain is not just weight gain or abdominal weight gain, but our inability to manage our glycemic load. And in many cases, as we look at changes in obesity on the left and diabetes on the right over the last several decades, there is a significant correlation. So as obesity goes up, so does diabetes across the board to the point where both have increased to very high levels, which are unheard of over the last few decades. And again, something we're having a very difficult time managing. What I tell patients is, as you are dealing with inflammation in the gut, these inflammatory markers do not stay there. So it's very interesting that our adipokines, which are basically hormones from our fat cells, are ending up and being found in research studies in the shoulder joint, in the knee joint. And this is one of the reasons why obesity can have such a significant impact on pain. The next part of the vicious cycle is that as patients become more pained and more inflamed, they're having a more difficult time managing with their conventional tools. So it is not just that they are stopping doing what they know is helpful, but in many cases, there is a significant difficulty because of the pain, because of the change in quality of life and depression and sleep, that there's just not enough resources to be able to manage. So I think as we reduce pain and inflammation, it also helps with management of other things like diabetes. I'm very interested in the area of environmental medicine, and one of the key things that we often see is that as we're trying to fix the diet, there's a lot of attention on reducing toxins, reducing processing, but in many ways, the rest of that person's life can be very toxic. It can be in a stressful scenario for many reasons. Obviously, we're in a very difficult time as a nation, but it can also have to do with noise pollution. It can have to do with toxins in the household, which may not have to do with dietary products, but just being in a toxic environment and not having the ability to go to green spaces and be in an environment that supports a reduction in inflammation. So I just want to make the point that this is much bigger than what's on the plate, although starting at the plate can be very helpful for patients to understand the bigger picture. We also know that this happens in reverse. So it's not just that the gut causes the inflammation, which causes pain. It sometimes is also the dysbiosis, which then changes our tastes, and in some cases we think we're doing a positive thing by making small switches, but over time we've seen things like artificial sweeteners actually compound the problem. One of the main ways it does that is by promoting the dysbiosis that we are trying to avoid. And this is a small change that we tell our patients about, and part of our clinical trial is, try to get rid of all artificial aspects of your diet as much as you can, in addition to the processing, because that can have significant impact on your glycemic control, your inflammation, your gut inflammation, etc. In fact, it is such a strong trend that several studies have shown that just by looking at gut flora, we are able to detect in a blinded manner who is someone who's dealing with pain and who is someone who's not dealing with pain. So it's a very significant signature of what happens in our gut is typically what happens in our joint. So by putting this all together, hopefully I've made the case to make it a little bit clearer that when we end up seeing a patient with joint pain in our clinic, it is not something that just begins and ends in the joint. So it's just not typically, especially in a chronic model, because they had a injury or they overdid it. Those can obviously be triggers. Those can be exacerbating factors. It can be contributors. But in many cases, there's a long trend, a long bridge to the point of knee pain that often starts in the gut, increases with these toxin and endotoxic products, which then cause an inflammatory cascade, which is one of the reasons that we then end up with high levels of these markers and changes in our immune system, the gut-related immune system, which ends up causing joint pain. So in many aspects, that is a model that we as clinicians are becoming more familiar with, and one that we are sharing with our patients, that taking care of our gut, taking care of our environment makes a significant impact on our pain. The next thing is, how do you put it together for patients in a way that makes them able to manage their pain? And one of the key things is trying to put it in a stepwise fashion. So this is a model that we've used in our clinic for over a decade, and it's the SANE approach, simply because, and this is not a original model, it's something that's been used in behavioral care for a long time, that our environment, our sleep and stress, our activity, our nutrition, and how our environment is put together, how nourishing it is, what our relationships are like, can make such a big impact on our pain management. And then nutrition is important, but how do we put it together? So one of the key things is how insane is the person's lifestyle when they come in? How inconsistent are the sleep and the stress management, et cetera? And how can we help to put a mirror on that in a way that the patient gets it? They may think that they're doing a great job because they're having that diet soda. They may think they're doing a great job because of something else they're eating that really may not be what's really going to be their solution. So sometimes it's just talking about it, showing them some of the studies. Sometimes it's doing diagnostics, whether it's serum markers or microbiome markers. One of the key things we use is zonulin and LPS. As you remember, when we talked about the Big Bang, one of the key things that gets released is LPS, lipopolysaccharide. And this is an example of one of the patients in our trial who, he was a pre-diabetic, thought he was doing, good things, and was on all the right medication, was eating things that were, low sugar, but had a lot of artificial products. And he had gut symptoms, history of IBS, and we did this study, and he was through the roof. And so this helped him, as well as us, know we have to put on a full court press when we are trying to help your pain. In that person's case, he was having joint pain. He was having a lot of other inflammatory issues, dermatitis, et cetera. So this can help the patient understand what needs to be done. This is also the original labs. We'll look at the follow-up, but there was an increase in glucose and insulin. There was reduction in some of the hormones that are key for fighting pain, like testosterone. Leptin was elevated, as we would expect. And adiponectin, which is the good guy, we want that to be a little bit higher, was not as high as we'd like. So all the makings on the markers to show that the Big Bang was going on. This is just a study to show that zonulin, which originally was looked at as a measure of gut permeability, is actually much more linked in some studies to obesity, hyperlipidemia, and pain. So it is a bridge molecule, I would say, or bridge marker, in that detecting it, an elevation, helps to understand why there might be issues with inflammation and pain and cardiovascular dysfunction. This is another interesting study to also make that case that those folks who had the highest levels of zonulin and another gut marker and LPS, in many cases had the highest levels of anxiety and depression. So it's linked, our gut is linked to our brain, and we're just getting more studies to help prove that. We also talk about if the patients are doing everything they can in their dietary approach, it's also important to get enough sleep to help those things take hold. So we know that if people have disrupted sleep, and if they can, improve their sleep hygiene, et cetera, we work a lot on that. We also know that as patients increase their mindfulness approaches, might be things such as meditation, mindfulness, being out in green spaces. Those are all important to also help with supporting the gut, which then also helps with reducing gut inflammation. I'm not going to spend too much time on it, but we do endorse having patients increase their activity as tolerated. Obviously, it's very difficult with some chronic pain issues because we know that increased activity can mean increase in flaring, especially in cases like fibromyalgia, where patients might, and migraine headache as an example, when they do too much, and it could be not even a lot in our, from our standpoint, it can be pain flaring. The key point here is the evidence shows that if you have a great exercise program with guidance, with support, and don't do too much in a kind of erratic manner, but do it consistently like you're doing with your diet or daily medication, it can be significantly helpful. And it also has some of its benefits because it helps with supporting the gut microbiome, typically by improving production of short-chain fatty acids, which we know can be very anti-inflammatory and helping with supporting our endocannabinoid system. And this corroborates that the short-chain fatty acids are increased typically after several weeks, at least a month of consistent exercise. But it's one of those things that you can't expect it to continue unless you are making lifelong changes and do this on a regular, most days of the week standpoint. And that's what the evidence seems to show. But it's also another case in point how everything is connected. So after we shore up, hopefully, the sleep and activity and stress management, we try to look at the environment, especially the environment of our nutrition. And one of the key things that we've looked at is that there's many aspects of diet. There's many diets that are touted, whether it's ketogenic diet, low glycemic diet, Mediterranean diet. Those can all be beneficial in the right setting, and it has to be individualized. But there's also foundational things that cut through many of these diets that we try to focus on. And before we talked about the standard American diet, and when we try to transition to more of the opposite of that, we talk about where to start. And in many cases, this has to do with individualizing it. So a patient may come in and they're eating all their meals on the road, and they're eating them very quickly. So you might start with pace, and you might start with the pattern and the location of what they're eating and their relationship to the food. In other cases, you might have to do with somebody who's having highly processed foods, or somebody who's not aware of glycemic load, or may not have foods that are quite variable. So there's not a colorful array of foods that we know also is very important for gut diversity, and foods that may, or diets that may be depleted. So it's not about doing all of this at once, but looking at how you can pick and choose areas and go down the list. But I think one of the key things is, how does that patient mindfully begin the process of planning their meals? This is a great website, eatingmindfully.com, and there's similar ones that really talk about how a lot of the work we get, a lot of benefit we get from our diet is really looking at how we are able to make proper choices at the beginning, what we put in our fridge, what we put in our pantry, and how we prepare the foods, again, in a way to reduce glycation products and create a supportive environment with their entire family. Where we also start many times is if they're a low fruit and vegetable intake person, how do we increase that? Can we increase it with whole foods, or those whole foods put into non-processed patterns, such as some of the detox shakes that we're going to be talking about a little bit, to increase that 1 or 2 servings a day to 5 or 6, and going up towards double digits if we can, to help increase their fiber, to help increase all their polyphenols and phytonutrients. There are often good resources like the Environmental Working Group, which I like quite a bit. because there's always another option, and patients may not like a lot of the things on this list, but they're going to typically find one or two, hopefully more, that really speaks to them, or if they haven't tried it, trying it in various ways to help find ways that are going to improve their inflammatory status while also not increasing their toxic status. And the environmental working group helps to help patients choose wisely. So as we begin the process of understanding how foods improve pain, we've talked about how they increase pain. We also begin the process of looking at how these polyphenol-rich foods, high in fiber, high in fruits and vegetable intake, can improve pain. So this is a very preliminary study that looked at fibromyalgia patients. All it did was try to increase their polyphenol intake in various ways, and found that as this was happening, pain reduced and quality of life improved. And you could argue part of this has a lot to do with the fact that that person's diet, especially if they've had this pain for a long time, had become more towards a standard American diet, whether or not that person was aware of it. And over time, we're just beginning the process of switching it back to a more pain-relieving diet. And again, returning to our model here, I'm going to go down the list to talk about a few more of the items here. Low glycemic patterns are important because many times our patients are going after those quick hit foods that may be high carb, maybe high refined carbs. And in many cases, we often try to get them to find ways, including balancing healthy fats with whatever they're eating, so that the carbs, if they're a big part of their diet, are not going to have a glycemic hit, causing then an insulin spike, which then can cause an inflammatory spike. This has also been shown to increase adiponectin, the hormone from adipose tissue, among other health benefits, including supporting their gut microbiome. There's a number of research articles which are basically showing the same thing, which helped inform the study that we did, which was that if you improve patients' intake of polyphenols in a low glycemic dietary pattern, you're typically going to help them reduce their inflammation, which in most cases is going to help them reduce their pain. One very neat example is also one which we tried to incorporate is teaching patients how to cook. And this doesn't have to be done in your clinic, but there's great videos, there's a lot of great online courses which help patients. This is actually a study a little bit older, which showed that those patients who undertook the Mediterranean dietary pattern with rheumatoid arthritis as one of their conditions were significantly able to improve their pain and quality of life while also being quite cost effective. So it's a lot about empowering patients to understand that this is a pattern that's doable in any environment, even though this is not one that they may have been introduced to early in life. Just to talk a little bit about supplements, there's a number of these that have been linked to pain and inflammation. This is sort of a quick guide of typical recommendations. A lot of this, my practice based on blood levels, so vitamin D, obviously. Magnesium is a little bit trickier. Some of the B vitamins you can check, like B12. The key is if you are finding deficiencies, those are folks you may want to be more aggressive with. But even if you are not doing studies, these are very supportive substances. In many cases, some of the herbal products, obviously we don't have blood levels for these, but we do know they have a significant anti-inflammatory ability. We knew also, even without blood tests, the vast majority of our patients are going to be low in magnesium. Some are going to be extremely low, both because of their diet and because their pain condition is utilizing magnesium to stabilize their inflammatory system. And when that happens over long term, they're unable to do that, and their NMDA receptor and other areas are activated and increase their inflammatory burden. And this is just a nice review article that I found helpful in magnesium for the implications in all the chronic diseases, and pain being obviously very important for neurotransmission. Long term, which I would love to see more studies show that if we increase the intake of foods such as magnesium over time in a very severe pain state, such as diabetic neuropathy, we have much higher ability, as this shows, to at least stabilize it and not worsen it. And those who do not go on things like magnesium at appropriate level through a diet or supplementation tend to have a much higher increase in propagation of their pain. We also know that magnesium obviously is involved in a number of other processes which control muscle tension, stress level, autonomic dysfunction, and sleep. So it can have a win-win effect in many cases. Vitamin D, which is an important vitamin, is also really an anti-inflammatory cytokine modulator. So this is a nice diagram which shows that it really helps with our free radicals, our reactive oxygen species. It helps with supporting our glutathione production and reducing a number of the inflammatory cascades that can happen, which many of our pain patients, if they're on a standard American diet, have. And if they're low in this, they're not able to do a lot of this work. And in that case, as we've talked about, just like with a standard American diet, tends to provoke pain, increase nerve transmission, and cause those pain flares to happen more often. And vitamin D, when it's given, especially in patients who do have that inflammatory burden, whether it's TNF-alpha we're checking, as in this study, or CRP, it has been shown to decrease the level of inflammation as well as the associated pain. One of the key things that I like to always mention is it's not about one nutrient. So this is an elegant study, and there's a few like this that talked about if we're not looking at it as a triage model, as has been mentioned by Dr. Bruce Ames, that when we just support one supplement, let's say vitamin D, but we're not supporting magnesium, we're not going to be able to absorb that vitamin D that hopefully we're increasing in our diet or our supplementation. So it's really important about supporting the whole system, especially with key nutrients like vitamin D, magnesium, our B vitamins, etc. Our gut, especially if it's our patients are dealing with gut dysbiosis, it's important to think about probiotics, prebiotics in our diet, or supplementation to help support the work that's happening while they are trying to incorporate a less processed dietary intervention. That's not always that quick. It's not that easy. So in many cases, probiotics tend to be one additional supportive approach that we often endorse in our chronic pain patients, especially if their diet is going to take a while to transition. What is very interesting is we know that this also has a significant benefit in neurological states, likely because of the gut-brain connection, likely through autonomic connections, the vagal nerve modulation that we're learning more about. But there is some interesting studies, and we're going to be looking more about at this in an upcoming clinical trial in our clinic. Quick word about omega-3 has been mentioned. Obviously, we know it works across multiple systems, but one of the key things that we want to realize is that it is an anti-inflammatory, but because it's also affecting membrane stabilization, it also helps with mood. It also helps with joint mobility and stiffness. So in many cases, it's one of those things that goes on to the wayside when patients increase more omega-6s, more processed, unhealthy oils. Omega-6s can be definitely healthy, but in many cases, the types that our chronic pain patients are choosing are not going to be anti-inflammatory. So it's important to try to support their omega-3s. This is an interesting study out of UCLA, which basically showed that as you increase omega-3s, which is the H3, and you reduce omega-6s, which is the lower the L6, you get a significant reduction both in acute and chronic headache medications, which again speaks to the membrane stabilization. There's also a very interesting, typically overlooked aspect that omega-3s do support endorphin production, which is part of how we know they can also help with mood and pain reduction. As it was mentioned, and many of us are more and more aware of, omega-3s do also support the resolvin cascade that we do know goes on to improve that pain amplification that we've talked about that happens when we're low on magnesium, low on vitamin D, or increase the intake of the standard American diet. So the SPMs and similar products with the resolvins can be incredibly helpful to incorporate as part of that. And lastly, we need to think about lipids as part of the gut support system. We think of it typically as helping with inflammation, but really it helps with supporting the small chain fatty acids, the butyrates, and others that are a big part of that. So before we start talking about the clinical trial, just a quick point. I know we had a full lecture on it, so I'm not going to go into too much detail. But many of these pain states have been described as endocannabinoid deficiency states. And in many respects, if we're not aware of that, we may have a difficult time treating these already difficult conditions like fibromyalgia, IBS, interstitial cystitis, chronic migraine. So when we are using broad spectrum hemp products, I think it goes a long way to support everything else we're doing with omegas and the other nutrients. It's very well demonstrated that these levels are low in pain. This is just a migraine example. And as they are supported with diet and supplementation, they can have a significant effect while being very safe in helping the pain recovery journey. So this is just an example of trying to put those pieces together that I've talked about before we go into the clinical trial, of how somebody that's beginning on the joint pain journey, as this example shows, who is maybe on a high omega-6 diet, is having a lot of heavy meat intake, typically not in a mindful manner, having a lot of high salt, high carb meals, can then end up with increasing issues with gut dysbiosis, and then essentially their joint pain. So we're beginning to understand how all these pieces come together to create a pattern that can reverse this. And that's what we're going to talk about next. There's been some preliminary studies. This is a study out of University of Michigan, which basically took fibromyalgia patients, put them on a low-calorie diet, which was basically looking at if you are reducing inflammatory overload by excessive calories, can that in of itself work? And the answer is yes. If you take patients who are overweight or obese and help them reduce their weight, that obviously reduces the adipose tissue ability to increase inflammation. But in many cases, we need to, this is not necessarily a diet that can be helpful long-term. So we need to look at how this can be helpful in a long-term manner. This is another study that effectively added exercise with weight management diet. Again, wasn't a very wasn't a very focused, individualized diet. It was basically, let's cut out the calories and reduce your weight and see if that helps your knee pain. In many cases, we know it did, or it can, and it also reduces interleukin-6 levels. The key point is a 5% weight loss is very important, much more exponentially important for improving pain and function. So keeping that in mind when you're talking to your pain clients, it's not about we're gonna shave off 40 pounds or 50 pounds. It's about, let's talk about 5%. Can we start that process? And it's more about the process than the actual weight loss, because it's about de-inflaming the system as much as it is about reducing weight. And that was the overall trend that we looked at in our intervention that was just published last month. I was very, very glad that the data came to publication. It was a multi-year endeavor with multiple people at multiple institutions. And I'm going to talk a little more about how we put that together. So it was a pilot study, and the key point here is very individualized. So this is not a study at the get-go that we could have hundreds of patients or even dozens of patients. It was really to prove the concept that you could use a detoxification intervention in conjunction with your typical therapeutic lifestyle program, which has been used in other studies. And what we did was take these 12 subjects who had both obesity or excess weight with comorbidities, which often were pain-related, as well as cardiovascular. And they were in a group model, which we highly endorse as a way to build camaraderie. We didn't have anybody drop out over the 12 weeks. In fact, patients became friends during the process, supported each other, shared recipes and discussion, and were really there when you have the typical pitfalls of a therapeutic lifestyle program as they're changing very difficult and set in patterns. We also had a behavioralist that met during those 2 weeks. They had group exercise as well as exercise they did on their own. And again, our goal was modest, 5% weight loss while we looked at other markers. They used the Detox shake through standard process, which you're going to be hearing more about, which gave them appropriate amounts of protein. And they used the first month to ramp up to a certain level. That was the heaviest detoxification, and then ramp down as they continued with the second and third month, with the understanding that it's really important to sort of mop up the inflammation, clean up the dietary patterns while you create a long-term journey. And in many cases, patients also had blood testing initially prior to starting, and that's incredibly important, especially if their low vitamin D status is there. That's important to put into place to begin that anti-inflammatory process before you set in a lot of major other changes. We also looked at toxin load, which was, these patients were highly studied in multiple parameters. One of them was looking at toxic load. We looked at porphyrin levels, and the majority had high normal or elevated levels, which by the end of the 28-day initial month of the study had significantly reduced. But what most patients come in the door expecting and wanting is this going to help me with my weight loss? And in many cases, or in looking at the average of the 12, we had significant across the board improvement. I tend to not worry as much about overall weight and BMI, which many of our patients still are very important. I try to look at things like body fat percentage and waist circumference, because those are as highly or more specifically linked to long-term cardiovascular health and overall health. I was also very interested in some of our blood parameters, blood markers, obviously improving elevated homocysteine, reducing leptin, which we did by about half, and improving vitamin D and B12 status, which we know is important for weight loss. And some of the more important intestinal barriers, which also improved significantly, were zonulin and LPS, as a sign that we were trying to quell that that large dysbiosis, or that big bang that was happening in our patients long term. Brief pain inventory, which was looking at the patient's pain, also significantly improved both on the level of pain as well as how intense that pain was affecting their quality of life. Probably the most important aspect of this is compliance, because you want patients to be able to comply with the program. And we had very high marks in the high 4s across the board, looking at would they continue the program, were they satisfied. We looked at taste, we looked at a number of factors, and these patients were satisfied with it. And in fact, many of the folks that after they completed the 12 weeks wanted to reincorporate some of the detox shakes, because it was an easy way for them to fill their protein needs, their polyphenol needs, et cetera. And that's important to keep in mind. This is also looking at the patient I mentioned earlier who was on diabetic medication. We're able to significantly improve his glucose parameters while he was able to discontinue at least one of his medications. His hemoglobin A1C improved while he was doing that. We also saw improvement in his zonulin and leptin levels, and also looking at long-term improvement in adiponectin. The adiponectins do not move very quickly, but we were able to see some improvement in those areas. So the key points that I want to make in conclusion is that a lot of what we're talking about is not just improving pain, not just improving inflammation, not just improving gut dysbiosis or sleep or mood, anxiety, but understanding that those pieces of this complex puzzle are part of the same global entity that we're treating. So we're not targeting one thing, but I do find it very reassuring that when you look at the gut and when you look at toxin levels, if you can reduce those, you have a much better ability to help the overall very complex system. And I think that's part of the integrative approach. And it doesn't just include diet. It obviously includes a lot of other things that I think need to also be kept in mind. As we talked about with our SANE approach, it's important to talk about, is this person having a lot of sensitivities? It may involve, dietary eliminations. Are they having a lot of behavioral struggles? You need to incorporate behavioral strategies, but really trying to make the case that what helps the gut will help the joints, will help the fibro, will help the migraines, while also improves overall quality of life and cognition is really important. And to put that into perspective, I just wanted to put this recent study that I think is important for folks to maybe review when they have time. Dr. Fasano, who really was one of the founding researchers looking at zonulin and gut permeability, did this wonderful recent study looking at really all diseases do begin in the gut, which many of our functional medicine and naturopathic providers have known for a very long time, but we are beginning to understand in all aspects of medicine. And this does a great job of reviewing that. And also this other study, which looked at the fact that as you improve zonulin and LPS and these toxin levels, you are not only helping that person's pain and inflammation as just markers or a number, but you're also improving their overall quality of life and their long-term and their longevity to reduce their chance of a heart attack, their ability to reach a very healthy, long life. The last study is really a review of how helping the gut helps not only the patient, but our entire society to live in a cleaner environment where we all have more ability to really enjoy as much of the aspects of our life as we can. So it's really about how can we support the gut and everything that goes to influence it. A few resources that I do want to mention. The University of Arizona has a great free CME program, Environmental Health, because many clinicians are interested in that, but it's a very complex topic area. So I did want to give that resource. There's a great new book out by a friend of mine, Dr. Cohn, is a rheumatologist, called Non-Toxic, Living Healthy in a Chemical World. I mentioned the Environmental Working Group, and toxinfuture.org is also a great website, so you can better understand where chemicals might reside in a greater environment to help that detoxification process in a much more global manner. And I'm going to end there. I know I've covered a lot, but hopefully this has been helpful in helping your clients as they try to detoxify and go on to a more pain-free life. Thank you so much.